What do you see in the role of surgery in type 2 diabetes?
The role of surgery is quite strong in patients of even mild degrees of obesity with type 2 diabetes as a treatment that you should use if people have not failed the first few options. So we would all agree that anybody with diabetes should start by trying to diet better and exercise more. Simple stuff, completely harmless. And if that works, no one would advocate the use of any medicine or surgery. And then, if it doesn't work, which is usually the case, there are some very simple medicines that are usually considered the first line of therapy, and I would agree. Metformin is the most obvious one. And another is a class of drugs called sulfonylureas. If both of those are insufficient, which they are in many cases, then I think the role of surgery is to be one of the options that could be considered next, along with all the other classes of drugs that you might consider. So after those interventions, exercise and diet, metformin, sulfonylureas. If those haven't worked, your choices are insulin, a class of drug called glitazones, another one called acarbose, another one called DPP-4 inhibitors, and another one called GLP-1 agonists. Just considered 5 different classes of diabetes drugs, or surgery. And I would think surgery is one of the options that could be an alternative to be considered among that group of medicines after the first really simple ones have failed.
Can normal weight patients benefit from this metabolic surgery?
Yes, if they have diabetes. So the principle of metabolic surgery is usually applied to surgery performed to treat diabetes. And there are people who are not obese and do have diabetes. If they have type 1 diabetes, which is the autoimmune kind where the immune system gets confused and attacks your own cells that make insulin, we don't pretend that surgery will help that. That only represents 5% of all diabetes. For the other 95% of common type 2 diabetes, surgery seems to be beneficial to treat that in people of all BMI ranges, although the amount of evidence for really low body weight people is pretty small and being developed. But there's a lot of information on benefits of surgery to treat diabetes in highly obese people, moderately obese people, mildly obese people, and to some extent there's a pretty good evidence base in overweight people. Now if you ask about truly normal weight diabetic people, which sometimes happens among vulnerable populations like East Asians and South Asians, there's a lot of people that you wouldn't look at them and think they're obese or even overweight, but they may have diabetes. We think that it's beneficial in them too, but we're currently working on clinical trials to make sure that that's true. So the real solid data to support that are underway.
Professor, is the surgery cheaper in the long run?
Some studies show that bariatric surgery will eventually pay for itself, but it takes quite a few years for that to happen because the operation itself has a big upfront cost. But even thinking that way is not the right way to think of it. No other intervention in medicine is asked to be, we do not ask any other intervention in medicine to be free or cost saving or make us money. We ask that it be reasonably affordable. So if you have heart surgery, that costs money for sure. You never get that back. But the question is, was it affordable for the benefit it provides? And the main measurement for that is how much money does it cost to provide 1 year of good quality living. It's called a quality adjusted life year. And the cost of surgery for that ranges between $3,000 and $13,000 depending on which study you read. The widely accepted societal standard for cost-effective healthcare interventions is $50,000 per quality adjusted life year. That's about what renal dialysis costs. So everybody would say anything below $50,000 is affordable healthcare. In my country, healthcare insurance payers even do pay for things that are much more than $50,000, like lung reduction surgery costs $200,000 per quality life year. So the answer is, bariatric surgery is very cost-effective and affordable. As to whether it's a freebie, no, it may not pay for itself outright, but it's very affordable for the benefit it confers on health.
Are there any negative side effects for this surgery?
Yes, there are. All operations carry some risk, but it's important to put them in the perspective of what's the risk of not having the operation. So the safety of gastric bypass in terms of mortality is about the same as these common operations. Gastric banding is even safer than that, and gastric, much safer, it's almost no one ever dies from that. And gastric, sleeve gastrectomy lies between the two. Safer than gastric bypass, not quite as safe as gastric banding, but they're all in the range of gallbladder removal or less. Some people will have other complications though that are not life-threatening, but annoying. They have to take antibiotics or occasionally have to go back for a second operation to repair a leak or some such thing. Chances of something like that happening are in the neighborhood of 5 to 10% with most bariatric operations. But how does the risk of problems from the surgery weigh against the risk of troubles from continuing to be diabetic if you don't have the surgery? And there's a lot of studies now on what we call all-cause mortality. Just says, it asks the question, among people who choose to have surgery, how much do they die over the next 10 years compared to similar people who choose not to have surgery? And there are about 10 different studies and they all have the same result. The all-cause mortality from patients who have surgery, who are obese enough to qualify by the current standards, is less than the deaths among people who choose not to have the surgery and are also obese enough to qualify by our current standards. Because in the latter group, they remain obese and possibly diabetic, and they might have blood pressure problems and cholesterol problems, all of which are not as treated as well without surgery.
Professor, do you have any final comments for our listeners?
I guess if there's a take-home message for people considering whether surgery might be for them, it's this. If you're even moderately or severely obese, and you're wondering whether surgery is for you and you're scared that it might be dangerous, it's very compelling evidence that shows that if you have the operation, in the long run, there's much better chance that you're going to live longer than if you choose not to have bariatric surgery and just plug away with diet, exercise, and medicines to try to treat your obesity. This is clear for people who are moderately to severely obese. And it's especially true if you also have diabetes. The reduction in diabetes-related deaths is 92% for the people who have surgery compared to those who don't. It's a more complicated story for people who are not obese or mildly overweight and have diabetes. We think that surgery is also beneficial for them, and it certainly gets rid of diabetes more than medicines do in the short run, like 1 or 2 or 3 years. But we don't yet have data on whether that translates into longer life.
Thank you so much for your time, Dr. Cummings.
Entirely my pleasure, and thank you for your interest in this important field. It's a pleasure to be able to get the information out to the viewing public about this powerful tool against obesity and diabetes, which is very underused. Among people qualified for bariatric surgery, under even just the strictest of guidelines, about 1% of people who qualify actually have the operation, and many, many more than that